Hello, everyone. Thanks for attending. I'm very grateful to have this opportunity. My thanks to Joe and the Center for their support for this event today. So the focus of my talk is on health issues pertaining to the use of cannabis. I hope you'll find this a balanced talk. I'm trying to adhere to science-based information. But the intersection of cannabis use and health is really quite complex. I'm going to try to be sensitive to the following principles. The science on this topic is evolving. Conclusive statements are very rare. And keep this in mind, what we think we know now or what we think we do not know today may not be the case in the future. There is a lot of material to cover, and I apologize if I move quickly. We hopefully will have time for Q&A at the end, but also feel free to contact me if you have follow-up questions that we don't get to. A professional disclosure for everyone. I am a member of what's called the Smart Approaches to Marijuana Minnesota. We are the state action group for the national group of Smart Approaches to Marijuana. Our mission is to educate the citizens of Minnesota on the research and science of marijuana usage with scientific understanding of marijuana's harms and potential as medicine. So at this point, the public health position of our group is that the current science does not support the commercialization and normalization of recreational marijuana use. But as you'll see in my talk, I'm really going to dig into some of this science, and I'm hoping you also will come to some public health positions on the topic. A personal disclosure, realizing it's Friday the 13th, I just want to let you know I'm not superstitious. I'm sure everything's just going to go fine with this talk. You know, Friday the 13th is kind of an interesting date. A lot of great things have happened. Black Sabbath debuted its first heavy metal album in 1970. A famous video game, one of the famous of all, Super Mario Brothers, was released on a Friday the 13th. The country of Finland takes Friday the 13th in a humorous way. So for example, if you go to the airport today, you would see this particular daily flight demarcation on the flight board, flight 666 to HEL. That's the airport code for Helsinki. So kudos to the Finnish for having a little humor with this day. I want to point you to some web-based resources before I get into the heart of the talk. I have 5 of them up here. The first 2 are color green because of my view that you would go to those sites to get information that supports the legalization of marijuana. The long-standing group NORML, National Organization for the Reform of Marijuana Laws, and the other prominent one, Marijuana Policy Project. The other 3 would be sites where you'd get a lot of information about the potential negative health impacts. There's National Institute on Drug Abuse. Their specific site on marijuana has a link there. The national group SAM is learnaboutsam.org. A lot of resources. They try to update weekly about the latest. And then a third one, National Marijuana Initiative. Interesting sites, we'll return to that in a bit. One thing about a recent publication from the national group called Lessons Learned from State Marijuana Legalization. Every year they come out with a report that does an effort of trying to compare health and public health impacts of states that have legalized marijuana and compared to those states that have not. And interesting report. We're going to talk a little bit more about how to understand the information from those reports. So here is the overview of my talk. There will be some background topics, and then I'm going to get into reviewing some of the major reviews of health effects, drill more deeply into 4 topics: mental health, driving impairment issue, cannabis as medicine, and then prevention and treatment issues, wrap it up with a summary. Many research challenges when trying to either study this complex plant or interpreting findings from people's studies. Here's just some reasons why it's very complex to understand the research behind cannabis. The plant contains hundreds of chemicals. The use of the drug and all of its cannabinoids impacts many regions of the brain, so it can be hard to isolate and identify the acute effects because it might be affecting so many, and the interactions of those effects can lead you down the wrong path of how to interpret certain data. Because it's still a Schedule I drug, with some exceptions we'll talk about, it can make it somewhat difficult for scientists to study it, although this is the case with all Schedule I drugs. It is doable, but it can impede the pace of the progress. Animal models are difficult to use. Animal models are important in studying the acute effects and sometimes the chronic effects of illicit drugs, because you can, of course, control for things you couldn't with humans. And if you can't administer the drug easily to animals, you have a lot of problems in answering some important questions from the animal model side of things. It's difficult to measure intoxication in humans. This is a problem when it's possible, because it is in Canada, Europe, and in some states in the US, to look at acute effects in humans that come into the lab, but then trying to measure severity of intoxication with performance, that's problematic. And then there's the last one, the rapid changes in use and perceptions of use make it somewhat difficult to understand the literature. So I have the metaphor up here of a rearview mirror. And I'm going to take a quote from a recent article by NIDA director as well as colleagues. And the quote is this: "The changing landscape of cannabis, which includes the strains of THC potency, new routes of administration, novel drug combinations, and a culture of rapidly changing norms and perceptions, raise the possibility that our current limited knowledge may only apply to the ways the drug was used in the past." And so, two big changes. One is that delivery and vaping has changed the landscape of use, perception, as well as ease at which you can deliver more high potent forms of THC, and just the typical amount of THC that's available is also changing quite a bit. So the graph represents the average THC amount in confiscated cannabis products, showing that average changing from 95 to 2019. So it's about triple, approximately 4% to approximately 14%. And so much of the literature is based on humans who used in prior years with much lower THC content levels. And so going forward, things may change quite a bit, particularly if the average use is going to be much more than 4%. Then it's also difficult to address complex public health questions with research. We can be misled as we look back in history with many public health topics and believe that maybe something is safe when it might not be so safe. So here are four potential sources of bias or errors when interpreting public health data. I'll address each of these with some examples. The first one I'm going to refer to as confirmation bias, the common human trait of perhaps leaning one's interpretation on information you receive based on your existing value or your existing perception of things. And of course, it occurs among all of us. It's probably quite human, and it occurs in science as well. So here's one example. There's a big debate of the extent to which legalization is going to alter the rate of adolescent use. And so many people point to Colorado, which is collecting a lot of data along these lines and indicating that it really doesn't look that bad. So here's a comparison of past month use among 12 to 17-year-olds based on the NISTA survey. And the blue is pre-legalization. The orange is post-legalization, and it's basically a wash. 1% increase is insignificant. So that's often pointed to as, see, Colorado legalized it, and they legalize it in a big way, and adolescent use has not gone up. And then the other side also, however, points to this. Nationally, marijuana use is decreasing on a rate of about 7% across all states. So Colorado's flat line doesn't look so good when you realize that actually a lot of teenagers are using less. So both sides sort of have an argument, and as you can imagine, depending on perhaps which side of the fence you're talking to, they will lean on or point to one side versus the other. Another example, I would make a case of confirmation bias occurs with the current debate about vaping THC. As you may know, vaping anything is being associated with lung illnesses. First bullet up there is the, I think, pretty current of CDC's latest data of almost 2,200 vaping-related lung injury cases and 48 deaths. The FDA has tested many of the products, and THC is believed to be present in most of them. And also there's an argument that these THC products have been adulterated with vitamin E acetate. So what do people make of these data? From the anti-legalization side of things, one group that's very heavy against legalizing marijuana, their quote is this: while the marijuana industry insists that the THC cartridge brands making people sick are purchased exclusively from illicit black market dealers, several individual states report some patients have bought them from licensed dispensaries. So they emphasize the fact it's just not all the black market, as you can imagine. Pro-cannabis side, one of the organizations had this quote: the THC vaping illness are due to unregulated and illegal manufacturers and distributors who are diluting the product with contaminants. So who is right and who emphasizes which side of the argument? You can imagine it can depend who you're listening to. Another thing to keep in mind is a lot of studies, particularly some of the early ones when there's perhaps not a lot of resources yet or ability to do meta-analyses, they're flawed with small sample sizes. I'm going to highlight the famous Dunedin study as an example of this. This was the study in New Zealand that was able to link changes in IQ score with marijuana use patterns across several years. So while the study started when the cohort was in their infancy, at age 13, an IQ test was given, and then at the far end, you'll see in red, age 38, the IQ test was repeated. And then in between, there were the assessments at 18, 21, and 32 years of age. And in those years, the yellow years, the participants were asked about their marijuana use. And so they linked the pattern of marijuana use across those three assessments. You'll see how it is coming up. And then they wanted to see if there were changes in the IQ scores from 13 to 38. So it's a longitudinal sample, about 1,000 cases, and there's all these assessment points. And here's how the data looked. It depended on whether you started using marijuana before age 18, and it depended on whether you're a chronic user if you had a big IQ drop. And that's the far right red bar, and I put the little reminder there, 8 IQ point drop on average among early and heavy users. The other groups that weren't as heavy of use or those that waited until after age 18 to start using, they either showed no IQ change or was negligible. So the 8 IQ point drop hit the media, and of course it was published. It's an excellent study. It's rigorous. It got published by a very prominent journal in 2012. I'm not quibbling about that. And the authors were very open about all the caveats. But an important caveat is sample size. So I've just put above the bars, in little white boxes the sample sizes for these various groups. So nothing all that large. In fact, the big group that you really took home the 8 IQ point drop is the sample size is 21. And so you always have to be cautious when even a good study, it's longitudinal and they had great retention rates and a rigorous assessment, but you have to be cautious when sample sizes are so small. Good news is NIH is underway with a long and extensive and rigorous longitudinal study. They are recruiting 13,000 children from ages 10 to 20 and are going to assess the effects of drugs and other lifestyle habits on brain development and functioning and all other kinds of health outcomes, called the ABCD study, or the Adolescent Brain Cognitive Development Study. A few weeks back, there was a presentation on the study by the center, and so you could go to the center's webinar library and download that talk. There are 13 universities participating in this multi-site study, and one of the sites is University of Minnesota. So that webinar is conducted by the 2 primary investigators here at the university. Okay, let me move to this, the last 2 considerations. You have to be careful about public health data. Is it community level or is it individual level? And how long is the time window? How much time has been examined to see if there's an impact of some kind of agent, a negative agent we're going to consider, cannabis for the sake of this argument, and possible health impacts. I think both of these potential sources of how you interpret data overlays with the question of, will legalization help alleviate the opioid abuse crisis? It's in the literature and discussed a lot among public health officials. The first study that came out in 2014 led to this bulletin board. States that legalized marijuana had 25% fewer opioid-related deaths. That's actually accurate. They were quoting from Bach-Huber's study, which reported that if you compared medical cannabis law states to those that didn't have cannabis laws, those with the laws had 25% lower annual opioid overdose mortality rates. So it looked like, whoa, if you had medical cannabis available, you could help solve the opioid crisis. Similar study published by Wen and Hockenberry in 2018. They looked at both medical marijuana states and those that had and also recreational marijuana and found improved opioid abuse data. They had and showed reports of lower rate of opioid prescribing and lower rate of opioid prescribing in both types of states, 5.9% and 6.4%. Again, another example where, gee, maybe having medical or even recreational access to marijuana could help another nasty public health problem. So one has to always be cautious when epidemiological based community level data are examined to try to understand complex public health problems. Not only are there a lot of confounds involved, but because it's not longitudinal or individual level, you may actually be picking up trends that are due to other factors. Also, the time frame that's being examined was quite short. So those first 2 rounds of studies I showed you, let's follow it up with some later rounds. And the big one is the follow-up to the Bach-Huber study done by Shover and colleagues. So they replicated the method done by Bach-Huber, but they included an additional 7 years of data. So this allowed them to look at a period much longer in which overdose death rates were still rising and more states had legalized recreational and medical marijuana. So they then looked at a much bigger data set from 1999 to 2017. Bach-Huber only looked at 1999 to 2010. And what did the authors found? They pretty much found the opposite of the original study. They found a 22.7 increase in overdose deaths in the states with medical cannabis laws. And all of those recreational states also had medical cannabis. So it's lumping medical and recreational law states. Their conclusion, research into therapeutic potential of cannabis should continue, but the claim that enacting medical cannabis laws will reduce opioid overdose death should be met with skepticism. 3 other later round studies I'll point to. Olafson looked at individual level data, had wave 1 data in 2001, 2002, and then longitudinally had wave 2 data, same sample, and he's looking at to what extent did marijuana users at wave 1, who are not opioid users, however, at wave 2 are using opioid, and compared that to a control group, and the odds of later opioid abuse, which was either defined by having opioid use disorder or just using opioids, was a double to almost triple, 2.2 and 2.6 greater likelihood of downstream using opioid if you were early a cannabis user. So the protective effect of cannabis not showing up there. This slide just shows the Olson data as a function of, well, how heavy of a marijuana user were you at wave 1, and the more heavy users at wave 1, they even had the greater odds ratio of later opioid. A longitudinal study in Australia looked at 1,500 individuals. They had baseline data and 4-year follow-up. All of them had chronic non-cancer pain, and they wanted to look at trends in their marijuana use, opioid use, and pain relief. And their conclusion was this: cannabis use was common in people with chronic non-cancer pain who had been prescribed opioids. But we found no evidence that cannabis use improved patient outcomes. There was no evidence that cannabis use reduced pain severity or interference or exerted an opioid sparing effect. And the last example, this summarized a lot of studies that had individual level data, 104 studies, 91 publications, half were randomized controlled trial. And this was looking at people getting treated for various forms of chronic non-cancer pain. And of course, they also examined then reported use of cannabis. Evidence for the effectiveness of cannabinoids in chronic non-cancer pain is limited. It seems unlikely that cannabinoids are highly effective medicines for this type of pain. An example, I think, where just be cautious with a complex topic that's studied early and it may not have the strongest design. So I'm going to go back to my list of all these sources of information and remind you of how things can be biased. They can be early, and one needs to make interpretations carefully. A little bit on legalization and use of the plant, my last background section. I'm just briefly mentioning a little bit on the history of cannabis in particularly the US and most westernized cultures. I'm just highlighting 4 things. 2 of them are red, 2 of them in green. The red meant really there was a bit of a downturn in popularity. In green, there was an uptick. The reefer madness period, I kiddingly call the 40s and 50s, where marijuana and all illicit drugs were viewed as quite dangerous and even criminalized. But tobacco use and alcohol became quite popular. 60s and 70s, we saw a reverse of that. You could call it the Woodstock generation. Keep in mind, cannabis back then, probably 3 or 4% THC potency. The 80s and 90s, we saw the crack epidemic, and it was a big push, public health push, for all illicit drugs to be viewed as quite dangerous. I put 1995 as a starting point of our current upswing in what we might say is a resumption of a push for legalization of cannabis. I called 1995 the important date because that's when California passed the Compassionate Use Act, and that really started the first medical marijuana state. And despite federal laws, almost 2/3 of states do have some legalization of marijuana. Here's the breakdown. You can make a case it's 33 states plus Washington, D.C. Among the 33, 11 of them have commercial use. The 11th state, Illinois, will kick in a couple weeks, January 1. 22 states are medical use only. That's us in Minnesota. Among those medical use only, there's great variability. on what is medicine, all the way from fairly liberal dispensaries where you can buy any type of product and deliver it any way you want, versus many states that restrict type of delivery have restricted lists of conditions. Some states have only CBD, the non-intoxicant compound in THC, as the medicine that's allowed. Interesting. Many people think it's inevitable that the country is going to go all commercialization for marijuana. I don't know about that. It's a great debate, political and public health debate. Just one perspective. 10 states in the past 2 years have applied the brakes to full legalization efforts. So there's the list. Several of them are out east. Minnesota is one of them. So what is the brakes? Well, it means that efforts to move bills through legislation or put a bill on the ballot for the public to vote have stopped or halted. That doesn't mean there won't be a resumption of them. So each election, it's worth always looking to see what states have done, including Minnesota, which might see some action in 2020 or 2021. I'm going to show 3 slides, 3 different states, and I'm going to ask you just to look at the colors. So this is Colorado, broken down into its various regions, counties, that is. And you'll notice, all right, there's a lot of green counties. This is Michigan, cities and townships, and you'll notice there's a lot of red there. The last state is Massachusetts, and you'll notice there's a lot of towns that are either red or orange. So 3 states, each of them had a little different color of their subsections or sub-districts. And why am I doing that? It's to remind us that even when a state goes full commercialization of marijuana, a lot of counties and townships ban or put a moratorium on commercial sales in their backyard. And so as you'll notice with the green in Colorado, the red in Michigan, and the red, orange in Massachusetts, it's a lot of communities have said, well, I guess the state passed it, but we're not interested in promoting the commercial sales in our backyard. So even within states that kind of go thumbs up, the brakes can be applied and are applied at a local level. If you analyzed where there are not colors in these 3 states, and I bet that's the case for all the other states that have commercialized it, you basically would see urban regions and college towns, with some exceptions. The plant is complex. It has over 400 chemicals. The ones that interest most people and scientists and users are THC, that is the intoxicant or the part of the plant that gets you high, and CBD or cannabidiol, which is psychoactive, but it doesn't get you high. It's not an intoxicant, and it's viewed as perhaps medicine. It still is a Schedule I plant. So all the cannabinoids in it are still considered Schedule I under federal law, and thus technically are illegal. So one exception, though, is pharmaceutical grade CBD, cannabidiol, that's been approved by the FDA, and it's included in one approved drug, Epidiolex. More on that later. So questions about legalization. Is THC and CBD approved for dietary supplements? Can it be sold? The FDA says no. How about CBD products as cosmetics? Well, the FDA does not have that in their jurisdiction, so that's a yes, although buyer beware. So there are CBD products sold, but they are cosmetics and creams. That's why the FDA doesn't put the clamps on it, because that's not their bailiwick. Hemp is no longer an illegal substance. Hemp is any part of the plant that has virtually no THC, and that amount is placed at 0.3%. It can be difficult to grow hemp to make sure all of the hemp doesn't have THC that exceeds that, and that's been a problem for hemp growers. So cannabinoid receptors are all over the brain, and they're related to many functions: movement, sensation, coordination, memory. They're related to the reward pathway region, which of course can lead to addiction, and they're also involved in the judgment region of the brain. So when you take and ingest THC, you're activating multiple regions of the brain, And that's why people are interested and concerned about how it might have an impact on all kinds of things related to brain development, movement and coordination, regulation of pain, etc. One metaphor used by Dr. Kim, Sion Kim from Boston, is the cannabinoid receptors are a bit like a volume dial. And so when you activate those receptors by taking THC, you're turning up the volume. And so it can affect and accentuate all kinds of aspects of the acute effects of the drug: pleasure, mood, pain, appetite, motivation, memory. And so it makes sense when people say they're high on marijuana, all kinds of things are a little bit different for him or her. Is the drug addictive? It's not the most addictive drug, I don't think, and the data would bear that out, but it can be addictive for chronic users. On the right is the change in release of an important addictive chemical, the action in your reward pathway region. You can see the difference between amphetamine and marijuana. The amphetamine action is of course very pronounced, and the marijuana action is less, but you do get an impact. Trying to compare drugs and their addictive potential is complex. An interesting study conducted by James Anthony back in the 90s, he took epidemiological data and charted the percent of people that met a dependence disorder if they used the drug, controlling for polydrug use. And you can see cannabis was at 10% figure, tobacco the highest at 32, psychedelics the lowest at 5. These rates would be much different nowadays, in part because the drugs have varied. So think of the analgesic bar over there, which now could include opioids. That's going to be much different. For example, stimulant would be different with methamphetamine. How about a difference for cannabis? If you look at more current estimates, you get a big range, 9 to 30%. That's going to depend again on whose study, if they're measuring historical or current. And one might make a case the more current studies are probably tapping people who use the more potent version of marijuana. Also, the risk does vary based on if you are an onset user during the adolescent years or not. And so experts have placed ranges of all the way up to 4 to 7 times greater risk if your use begins during the teenage years. How popular is it? Data from the most recent national household survey that I could find detailed tables for. So it was data collected in 16-17. 3 age groups. There you can see the percent that say at least once in the last year they used. Now, these represent the 40 states that had not legalized recreational cannabis use by the time that survey was done. Okay, so there's 40 of those that were clean. Obviously, some of those 40 have now gone the other way, but they were not in the group of having commercialized cannabis use. By the way, Minnesota rates are right in line with these trends. So not a news bulletin for those that know about drug use patterns across age groups. The so-called college age or young adult age group is the heaviest user, and then you get much lower uses in the other age groups. And what I've done here is overlay the numbers above the box of the 4 states that had substantial years of legalized recreational cannabis use by the time this survey was done in 16-17. Those states were Alaska, Oregon, Washington, and Colorado. They at least had legalization for, I think, at least 2 years. And then the insert numbers are the numbers from the prior slide. So you can just see the comparison. Where's the biggest difference? And quite a bit in the young and the young adult. The 26 plus doesn't show any difference. And as a perspective reminder, alcohol is still popular. The numbers are much higher across all age groups. when you compare that. Okay, let's get into some of the major reviews on health effects. There's a few of them I want to highlight. The 2014 review by Nora Volkoff and colleagues at NIDA, and they reviewed the literature at the time and looked at where there was at least some data on potential health effects associated with marijuana use. And then they made a judgment about, well, where was there low, medium, or high level of confidence that chronic marijuana use would contribute to adverse health effects. And here's the list. So low level was lung cancer, but then medium or high level of confidence linking, altered brain development, progression to the use of other drugs, increased risk of chronic psychosis disorders, and depression and anxiety, particularly in people with predisposition, addiction, motor vehicle accidents, diminished life achievement, which included cognitive impairment and poor educational outcome and symptoms of chronic bronchitis. Now, on this slide, I've colored 3 of them green because the authors also noted which ones of these problems showed a more pronounced effect if use started in adolescence. If marijuana use had early onset in adolescence and was altered brain development, addiction, and diminished life satisfaction and achievement. You're going to see this theme come up quite a bit for the next probably 30 minutes. Early use, particularly early use in adolescence, contributes to more problems or risk for more problems. And one of the concerns is that cannabinoid receptors, which are important for a wide range of human functions, are significantly important during brain development for these functions. So these cannabinoid receptors are viewed to be major drivers for the brain developing normal and healthy structures related to sensation, movement, judgment, memory, coordination. And so the concern is by activating these and essentially insulting them with THC, you're disrupting and interfering with the normal trajectories and mechanisms underlying brain maturation. Second big review is the National Academies, one that published in 2017. And in a similar way, they tried to categorize where there was strength or lack of strength of the data. And so they had 5 categories where the nature of the evidence was conclusive, substantial, moderate, limited, or none, linking health effects of cannabis. And so you can see the score box. They didn't think there was anything conclusive. There were 5 and 6 met substantial or moderate evidence, and then 7 limited, 7 not sufficient. You can read the report to get all the details. I thought I would highlight these 2, and I've actually summarized it, not all 11, but I've collapsed them into these 6 summary statements. Increased risk of motor vehicle crashes. That sounds familiar from the Volkoff. Increased risk for lung cancer, also similar to the Volkoff. Lower birth weight of the offspring when the mother is a smoker of cannabis. Cognitive impairments, that's similar to the Volkoff finding. Development of schizophrenia or other psychoses, highest risk among heavy users, very similar to the prior. And development of problem cannabis use when early onset of use, also similar to what the Volkoff report said. The third one, recent from Kroon, published just a few months ago. And they looked at heavy cannabis use, dependence, and brain functioning. And I'm going to go right to the conclusions. Heavy use is associated with psychiatric morbidity and with cognitive impairments, but noted that some of these impairments may recover after a period of abstinence. So when people have looked long-term at individuals, looks like there can be some recovery. But important moderators were age of onset, that sounds familiar, doesn't it? Heaviness of use, the severity or intensity, potency of the THC you're using, and whether you had a severe or less severe comorbid disorder. So, and the authors note the cognitive impairment issue about recovery, well, that may not show as much recovery for people, let's say, who are the worst case in terms of moderators. So I'll make an assumption here of what the authors are saying. If you were an early onset user, you were a heavy user, you used high potent THC, and you also had severe comorbid disorders, your cognitive impairments may not recover very well or at all after abstinence. The mental health topic has gotten a lot of attention. You've already seen a little bit in the several reviews. I thought I'd give a little more details. A review on this topic from Brenda Miller, Christine Miller, provides an overview of where she thought the data based on cross-sectional studies or longitudinal data as a function of various disorders could help us understand the possible connection between cannabis and mental health. And so her chapter in the book highlighted these 5 disorders. Risk of suicide was in the literature so much, and it wasn't always linked to depressive disorders, that she gave it a separate category. And then she summarized cross-sectional longitudinal data. Now the pluses in the boxes are my read of where she said the strength of the data are. So when there's a double plus, that meant that she reported and located several studies showing a strong connection. When there was a single plus in a box, she said there were only a few studies. And when there's nothing in the box, that would mean that there really isn't any data at all. So strongest number of studies, and probably the strongest data link is for schizophrenia. And you can see how the others fall out. And then she also discussed, well, when people studied early onset cannabis use, what did the data show? And for these 3 disorders, she found that early onset led to even a stronger association between cannabis use and that particular disorder: schizophrenia, bipolar, and risk of suicide. A couple European studies, one from Denmark, they were able to take case records of nearly 7,000 patients who, during a 10-year span, had received a diagnosis for what was called substance-induced psychosis. So that meant that they showed up at one of the hospitals, emergency rooms, and it looked like they were there because they had an acute reaction to some illicit drug. Well, then because people's health records are in national registries, we're able to see what the outcomes were of these individuals downstream. So they were able to, for many of the cases that particularly started early with that induced psychosis, over a 20-year period, they wanted to see what percent of cases now had at least once during the 20 years a diagnosis of some serious mental disorder. And 32% converted to either bipolar or schizophrenia over a 20-year period. So this doesn't mean the substance-induced psychosis caused it, but it could have been a marker that a high percent of them were at risk downstream. Cannabis use psychosis was associated with about half of those converted cases, and it was the drug with the highest specific conversion rate. And once again, the early onset showed to be a factor. The younger the age that you had this first induced psychosis episode, the higher the risk of that conversion being to schizophrenia. It would support the notion that perhaps if you have a vulnerability, you might alter the trajectory of that vulnerability with exposure to illicit substances, including marijuana. Another European study, multi-center, 900 patients with first episode psychosis were studied across 11 clinic sites, and then there was a comparison sample of about 1,200 controls from the same sites that did not have mental illness. So you got normals versus first episode psychosis, and then everyone is interviewed about their marijuana history. And cannabis use was associated with increased odds of being in the first episode psychotic group compared to the never users. So, they found perhaps what most people thought they would. You're going to get a higher rate of history of cannabis use in the psychosis group. They also looked at, well, does the odds of being in the psychosis group change based on your report of the kind of cannabis that you say you've been using? And so they had two groups, a low potency cannabis group and a high potency cannabis group, not by virtue of measuring the supply of these individuals. So they estimated low or high potency cannabis based on where these individuals were living when they were using, and using other data sets to document, well, what was the typical potency level at this period of time in this region of Europe near this center, and then coming up with a decision that this is the low end of the potency spectrum, this is at the high end. You can see in red, I've just shown the difference. The daily use of high potency cannabis meant that the odds then you were in the psychosis group was about 5 times above and beyond those in the normal group. Low potency cannabis that was daily use, it was still high, 3.2, but not as high as the severe potency. So potency could have an impact, not just use. The last one in this set, this was a 10-year follow-up study. So the European group had 200 psychotic patients, measured all kinds of functioning variables, and then 10 years later had a follow-up, and they compared cannabis use patterns on clinical, functional, and cognitive variables. 3 cannabis groups were identified: persistent users, ex-users, so they were using some, but they had stopped somewhere in the 10-year follow-up, and then there also was a group, never users. And what was found, perhaps predictable, the persistent users showed the worst outcomes. They had the more severe symptoms throughout the 10 years, and they had the lowest scores or poorer scores on all the functionality measures. The good news is patients who stopped using prior to the reassessment, in other words, they were the ex-users or desisters, showed a similar pattern to those who had never consumed. So there's some promising that you might be able to alter the potential negative trajectory of your psychosis if you halt using. Cannabis was compared to alcohol or any other drug in a group of psychotic individuals, and what was looked at was how early onset the psychosis was in these 3 groups. So the numbers above these bars represent the mean years earlier of age of onset of psychosis compared to non-drug using controls. So with that alcohol number of 0.28 basically says this group of psychotics who said they used alcohol in their adolescent years, they didn't have an age of onset of their psychosis any different than the psychotics who said they didn't use alcohol. Everyone, even the controls in the study are also those with psychosis, but they didn't use any substances. The cannabis bar, 2.7, means that those with psychosis that said they used cannabis in their youth years had the onset of, first episode onset of their psychosis 2.7 years earlier on average than the group that didn't use any drugs but eventually got psychosis. So almost 3-year earlier difference. And you can imagine that means you're suffering from the disorder for more years, and earlier onset of any disorder, particularly psychosis, means you're probably having a worse course of the illness. With humility, I'm going to tackle the driving impairment topic. There are some interesting questions with this topic. The big ones are, to what extent does THC impact performance tasks that are likely linked to driving ability? What is the prevalence of traffic fatalities linked to cannabis use? And then how do we measure THC, either roadside or otherwise? And what level of THC means a person is impaired? So there are some data to try to begin to address these complex questions. This is really an emerging science area, though. I'm showing you this slide as a reminder. Let's see. We have a lot of cannabinoid receptors in many regions of the brain that probably impact our driving ability. And by activating these receptors, we might perhaps disrupt our judgment, our coordination, movement. It makes sense to look at this topic, doesn't it? In the late 1980s, there was a publication that provided a synthesis of 87 experimental studies that looked at the level of THC concentration as a function of performance decrements. And so these were individuals who were either eating THC or were smoking it, getting measured for their THC level with blood testing, and then they were given various psychomotor tasks. It was done in Europe. So the higher the number, the worse the performance. So because it's measuring performance decrements. Several psychomotor tests were measured. This is a synthesis of it. These measures include tracking, reaction time, eye-hand coordination, distractibility. But you can see it's fairly linear association of concentration and decrements, both for eating and smoking. There are some indications in legalized states that the presence of THC impaired in driving is somewhat or very common. You can see more about this in the SAM Lessons Learned report. One example is Colorado. They publish a yearly report and look at detail on this whole topic of traffic deaths and marijuana. One of the graphs I put here for you. And then there are two indications of markers. There's 2009 when the state of Colorado went medical marijuana, and 2013 when they went commercial. And you can see trends, and not only before all of that, but also since those two important milestones. You could make a case that since commercialization, it's gone from 12% to 18%. That is, those that where the driver tested positive for THC. So in traffic deaths, drivers are always tested with serum tests. So this is the blood test, which is more rigorous. Interesting, if you go over to the little blip on the far right, 2017 to 2018. Can you see how the line goes down from 21 to 18? And is that showing an adaptation effect? Perhaps people are getting a little smarter. Public health messages are having an impact, and maybe Colorado is trying to improve this situation, and citizens are responding. But have to see how it plays out over the years. Canada is also very good at reporting these kind of data. Now, Canada has legalized for the entire country marijuana in 2018. These data are prior to that. They'll soon be reporting on it. But this just on the far left showed that percentage of fatally injured drivers testing positive either for alcohol or marijuana. You can see it's always a bit more for alcohol. It tends to be in the 30s. Marijuana lines tend to be in the mid-teens, but we're started to drift upward in roughly 2014. To the far right shows if you take more than one drug, it's even 2 drugs is worse. And interesting how 3 and 4 were not as bad as marijuana only. Not sure what to make of that. That's an interesting finding. But a couple of the big issues in measuring THC is, first of all, it's likely that drinking alcohol and smoking will have an additive effect. There's actually data from the Canadian report that shows that. And then the other problem is how to measure it and how long is somebody affected when they've ingested THC. It's a messy metabolite measurement problem. That's my silly phrase for this. There's both active THC metabolite, and that's basically what's getting you high, and that can last and be active in a person, create an intoxicant effect for several hours. For some of us, maybe only an hour. For some of us, longer. Kind of depends, again, on your tolerance level, how much you've used. I've seen reports that say for most people it's 3 to 4 hours where the active THC metabolite is having an impact on the user. Then there's something called inactive metabolite, THC-CU, which also is present in the system if you're using the active. The problem is it cannot be distinguished, these two types, in a urine test. The inactive metabolite is not, the current knowledge says, impacting your decision-making or your psychomotor skills. It's probably not having any deleterious effect on you, even though it's showing up on a urine test. The only way to distinguish the two is the expensive blood test. The inactive can be stored for weeks, even months, and what can trigger it to be even more elevated is stress. So imagine you smoked a week ago, you get pulled over, you've got plenty of the inactive, and then you get asked to give a test. Stress goes up, and of course it might show up positive on a urine test. One could call that a false positive. Also, the problem is not clear what level of active THC is makes a person impaired driver. So we made decisions about alcohol, even though that's a general line in the sand with 0.08. At least there's plenty of data to support it for most people. Obviously, there's big individual differences, but we're far away on that score when it comes to THC. If you want to learn more about this, interesting review of various roadside testing methods is provided by Dobry and his colleagues in a recent publication, Public Health. Here's a soundbite of their conclusions. There are different methods and devices for on-site oral testing for cannabis use, but it is unclear if these devices meet the necessary criteria to be implemented at the roadside. Still something that's going to take a lot more science and technology. So what about cannabis as medicine? This is an interesting topic. I'm going to just highlight two main questions here. Is smoke cannabis medicine, and what evidence exists for the health benefits of cannabis? Smoke medicine varies so much by potency and purity, and due to people's individual differences, it's as well as differences in absorption and metabolism, it's just not possible for the FDA to assess the potency or duration of its medicinal value and its side effects when we're talking about smoking the plant. It's just not reasonable to suggest that smoking marijuana, even under these conditions, is medical marijuana. The plant has over 400 compounds, and you may only be interested in 2 of them. Only THC and CBD at this point might have any medicinal value. So my goodness, taking in 398 compounds because you want 2, as you can imagine, quite perhaps silly and very inefficient way to deliver medicine. The National Academy's report did try to identify where there might be some evidence linking the medicinal value of cannabis or cannabinoids. So they said there was conclusive evidence or substantial evidence for 3 ailments, and here's the 3: chronic pain, nausea, based on those that are suffering from it because of chemotherapy, and then multiple sclerosis. So those 3 have surely gotten a lot of attention on the pharmaceutical side of things. So what is available? What is so-called legal? There's 2 synthetic versions of THC, Marinol and anabolone, and they have effectiveness or indicated for nausea, particularly from chemotherapy, reactions to chemotherapy. There is one FDA-approved medicine for a particular condition. It's Epidiolex. It's an oil. It's virtually 100% CBD. And so it's not an intoxicant. And it's approved for 2 forms of childhood epilepsy. So that went through the FDA pipeline. The FDA process for Sativex looked promising. Sativex is available in Canada and across Europe to treat pain and symptoms of MS. In the US, it made it all the way to phase 3. 60 US research sites were involved, hundreds of patients, and unfortunately it did not outperform placebo during that phase 3 process. So it's not approved. It surely was promising that it was going to treat neuropathic pain in the early months of outcome. But as you know, with the potential of placebo effect, you need to look at placebo groups versus active conditions more than just a short window of time. And when that window was extended, unfortunately, the drug did not outperform placebo. How about use of cannabis to treat mental disorders, PTSD, anxiety, depression? Recent review by Black and colleagues, summary bullets. There is scarce evidence to suggest that cannabinoids improve depressive disorders and symptoms, anxiety disorders, attention deficit hyperactivity, Tourette's, post-traumatic disorder, or psychosis. Very low quality evidence that pharmaceutical-based THC, so not the plant, but pharmaceutical THC, which means the synthetic version, leads to small improvement in symptoms of anxiety among individuals with other medical conditions. So a very limited thumbs up for where cannabis might help with mental disorders. How about to treat schizophrenia? Interesting early study looking at CBD. So that's the non-intoxicant version. It was a small exploratory double-blind study, only 6 weeks. So you got to do a longer trial to make sure you're not just capitalizing on placebo effects. But compared to that placebo group, the CBD group of psychotics significantly showed lower levels of the positive psychotic symptoms. You know, the hallucinations, delusions. Didn't have any effect on the negative symptoms, that, you know, the blunted affect, etc. But it was well tolerated. So that it's going to lead to you know, moving it into the more rigorous phases, since the early phase is somewhat promising. 3 sidebars about the issue of medicine and cannabis. Here's the list of cannabis qualifying conditions in Minnesota. You can see it's now quite a large list. The 2 at the bottom in red were just added about 2 weeks ago: chronic pain and macular degeneration. The 3 from the national academies are on this list, but you can see our list is much longer than the 3 that the Academy recommends. NIH is funding numerous studies. THC, CBD, and other cannabinoids are being examined as their potential medicine for several conditions and ailments. Got to stay tuned on that one. And then I thought I'd just mention the CBD hype. Ben and Jerry's would love to have the FDA approve it, because they've got plans, as they say, to help everyone chill out with CBD infused ice cream. It's not on the market. That's just a pre-FDA approved version of it. But I thought I'd give you the quote from Robert Dupont, who gave a talk on this topic. He's the ex-director of NIDA and the ex-director of the White House Office of Drug Policy, or one way of saying he was the ex-drug czar years back. His quote: "Commercial interests are putting CBD into more products than anyone could have imagined. Most consumers touting the benefits of CBD based on anecdotal claims are experiencing a placebo response in the midst of a financially driven mass delusion. This is not random placebo effect. People are taking these products with magical expectations. This delusion is contagious." I guess he is not happy about the CBD fad. My last core topic, prevention and treatment issues. I have 5 of them to walk you through, and then we'll have some time for discussion and questions. So I think when it comes to prevention and public health topics, if the state moves forward with commercialization, it's important to stay on top of where maybe the so-called big tobacco tactics will be used to try to push through pro-marijuana efforts. And in many states, what they have found is there is heavy marketing. The campaign often minimize or ignore potential harms. Perhaps the bias showing up on the dollar side of things. It's important to be critical about campaigns that say we're going to expand the economics of the state, and we're going to provide a lot of social benefits by legalizing cannabis. I think that's it's an important topic to look at critically. And be careful where there might be efforts, or at least interesting to look at, where there might be a push to minimize regulations to optimize access. Bills that don't allow local communities to regulate and to perhaps restrict commercialization, I think would be important issue and topic, and be interesting to see if the pro-marijuana push is trying to minimize some of those regulations. If we go forward with it, I think there can be a way to establish strong regulation systems. They can be expensive, they can be arduous, but it'd be important to put them in place, to have governance and compliance checks, to support research, hopefully prospective, establishing a longitudinal pattern would be important to examine really trend effects. And then there's the whole important topic of not just looking at tax revenue, but also considering social and health costs. Connecticut, which did not commercialize yet, they did a study that tried to compare what might be the cost versus what might be the revenue. So you can see the two sizes of the bars. The biggest bar, which has 206 million at the top, is their estimate of what would be the cost in all these different categories if legalization occurred, and then they compared it to what they thought might be revenue. They had even a low estimate, a high estimate of revenue. You can see their highest estimate of revenue is 113 million. Their estimate of the cost was 216. I caution everyone, it's very problematic to make these estimates. What might be more informative, if you look at the lessons learned report and see what states have been reporting that have legalized it for several years, what is the tax revenue they're drawing in? How does that compare to what was estimated or what was promised? And what are some of the estimated costs that are being incurred? Which also is difficult to do, even if you've had an effort to look at costs over several years and to try to place costs on some difficult social and complex topic areas is a sticky wicket. Also keep in mind that there can be very rigorous regulations, but it's easy for people to grow their own, or for some ways for a black market to still thrive, because it doesn't take much to grow a marijuana plant. I don't know if edibles would ever be included if the state went commercialization, but it'd be important to regulate that, because that can be a real source of problem for many people. The edibles often have high THC content. When you ingest by eating, the effect of THC is slow to onset, and the person might think they just need to keep eating because they're not feeling anything. And of course, then within a half hour, they've got an acute problem on their hands. In 4 states that allow edibles, Alaska, Colorado, Oregon, and Washington, they've now gotten pretty rigorous with requiring product labels. Other questions? If the debate progresses and if commercialization bills are advanced, questions to look at is, what kind of public health protections are included? What kind of health updates are required? Are costs included in the updates and not just what the tax revenues might be? And how will public health services be strengthened? Along those lines, let me just talk about some clinical issues. There is a trend that has been occurring for several years and likely continuing. That is that marijuana can be the drug of choice for people who are seeking treatment for a substance use disorder. So data based on some national treatment admission data collected, though, in the early 2000s, 2002 to 2012. And this breaks down the extent to which cannabis use disorder was the primary drug of choice among those admitted, and you see the versus other drugs, and broken down by age groups. So marijuana is the green bars, and the other colors represent alcohol, methamphetamine, and heroin. And you can see for teenagers and even young adults, marijuana is the most prevalent for the primary drug, um, perhaps the most severe substance use disorder the individual had when they sought treatment. You can make a case approximately 9 out of 10 of adolescents treated these days in substance abuse treatment programs have cannabis use disorder. And it's probably their primary, although you're still going to have coexisting. With clients, I think it's important to address misperceptions and myths about cannabis, particularly THC, reminding individuals that THC can be addictive and that they shouldn't just think I'll perhaps think about recovery for one of my drugs of abuse, but cannabis or marijuana is okay. I don't think that's perhaps a safe way to go. If they're taking medicine through the Minnesota Marijuana Medical Program, reminding him or her that the THC can be a problem. And you can get various forms of the medicine that has more CBD than THC, and don't have to get the heavy THC version because it's not clear that THC is medicine. And of course, still, it's not legal for open adult use of cannabis. And just another way of reminding those that are in a medical marijuana program, but they're getting treatment for chemical dependency, that there is abuse potential that can exist with THC-based medicines. Fortunately, this, like I've said, the state provides an option to get medicines. It's mostly CBD, a safer way to go for many individuals. So let me summarize. I'm going to summarize by reminding everyone that so much of what I talked about is also very relevant for other substances. And so I don't want to over-pathologize cannabis as somehow being uniquely harmful. They all have their story of harm, and they're relative. You can make a case that some drugs are more harmful than others, and maybe the legal ones are even more harmful than the ones that aren't legal. And of course, it's going to vary based on use patterns. I'm showing you this chart because this is an interesting example of a group of scientists trying to figure out what's the relative harm of various substances. Complicated study, but they had experts rate these various drug categories. You can see at the bottom how many there are, on potential for physical harm, social harm, and risk for dependence. And if you read the report, you can get separate charts for each of those 3 harm categories, but they also summarized and collapsed. And this is the synthesized chart. And I've just pointed to you where alcohol and tobacco were that had more on average harm linked to it than cannabis. Cannabis is there a little bit lower. To the far left, if you can't read the drug categories, is heroin. To the far right is khat, K-H-A-T, the low stimulant leaf that's chewed. Now, this was done in the early 2000s. Things vary. If cannabis becomes legal, widespread legal, and people are using the high potency THC, maybe that cannabis harm rating is changed. As maybe less people use tobacco because they realize of the health risks. Well, the harm rating of that could change. So it can be a moving target, but I just want to remind you that we have legalized 2 drugs in our culture, and they do carry with it harm. The question, civil libertarians and scientists ask, well, then why are we excluding cannabis? Because we allow other drugs that have harm. And then scientists might say, well, we don't necessarily have to legalize something that we know will have harm. Tobacco and alcohol are legal for various other reasons besides public health data. And then my chart of where I thought maybe the strongest data was for health issues. Maybe you could tell throughout the talk where I thought the data was pointing. And so I'm calling this my humble summary of where I thought there was substantial association of regular heavy cannabis use and negative health effects. So I'm not talking about acute effects. And I'm talking about over a long period of time in your chronic user, and if you use before adolescence or during adolescence and continue to use, there would be even more substantial association. So I gave 3 in yellow, that sort of tag of substantial association: mental health risk, risk to cognitive functioning, and elevated risk for cannabis use disorder. Brain development, I gave not the full yellow because I think there's too much indirect evidence and it's a bit early, I thought, to give it the substantial association. Now in the sources box, you're going to see summaries that I didn't talk about, and that's because for the sake of time and because of basic redundancy in conclusions, I didn't highlight all of them. But if you really want to dig into this deeper, you can go to some of these others that are new to the talk today.